Welcome everyone. My name's Heikki Uustal. I work at the JFK Johnson Rehabilitation Institute, part of the Hackensack Meridian Health care system. Today we're going to talk a little bit about best practices and standards of care for patients with lower limb loss. Before we get too far into the details, I want to make sure everyone understands that we as physiatrists are essentially team leaders for groups of specialists that work with our patients with disabilities. So let's run through that very quickly first. I, as a physiatrist, work with a team of professionals to both assess and care for patients with lower limb amputation. Those professionals would include a certified prosthetist orthotist, an individual who actually fabricates, manufactures the prosthesis and makes adjustments. I work with a physical therapist and occupational therapist who do much of the training for mobility, such as walking, and for self-care, feeding, dressing, and bathing. But we also use a variety of other professionals to help out with our patient care. Those might include other physicians for pain management or wound management, and other professionals for the patient's psychological well-being, such as psychology services, psychiatry services, and social services. In essence, we want to take a very holistic approach to management of these patients in caring for both their emotional well-being, their physical well-being, and restoring them to what was their previous life or as close as possible. Much of my job as the team leader, as the physiatrist in this group, is to assess the patient carefully for their underlying medical condition, their physical condition, essentially meaning their limb loss, and then try to assess their previous level of function and how that might relate to their future goals for returning to that level of function, using each team member to help achieve those goals. Sometimes the goals are practical and realistic, other times they may not be, but it's our job to educate the patient on what's possible. Many of our patients can return to activities even beyond what they were doing before with the encouragement and support of our team. All right, so now we're going to talk a little bit about the best practice, the timeline of care for our patients with lower limb amputation, and really explaining to the patient, the family, and the rest of the team members what will be happening over the next days, weeks, and months. It's often surprising how long this whole activity will take, and patients oftentimes have a misconception or have been given misinformation regarding how long this may take. So it's my job as the team leader, the physiatrist, to explain this to the patient and explain this to the team. So there really are 4 phases to this time period of lower limb loss and then the prosthetic fitting and rehabilitation. Ideally, the first phase would be before amputation. If I have the opportunity to talk to a patient prior to their amputation and to explain this process, the patient is more accepting and more compliant with the entire program. It's also much easier to explain exercises and start an exercise program well before the patient has the surgery and perhaps has the pain associated with surgery. So this pre-amputation phase is critical when it is available, but oftentimes it is not. Many of my patients have diabetes, dysvascular disease, and also have a sort of preamble to their amputation where there is a period of disability. That time period is oftentimes important in judging or gauging their recovery. If a patient is walking normally one day and has amputation and then gets into the rehabilitation program soon after, their recovery may be quicker. However, if they have a period of weeks, months, even years of disability prior to amputation, their recovery and their rehabilitation will be a bit slower. And it's my job to understand that. So let's take now the day of surgery, the day of amputation. Most commonly, I will see the patient a few days later or perhaps a week later once they've cleared that early surgical phase. They may be having pain, they may still be dealing with wound management, and certainly the disability of impaired mobility, impaired self-care, the overwhelming psychological stress of having lost a limb, the idea of dealing with their friends, their family members, perhaps work-related issues that they're not sure what to expect. So much of what we do during this second phase, which we'll call the pre-prosthetic phase, time from amputation to prosthetic fitting, most of what I do is education. I'm organizing the team, I'm bringing each of the team members into this group, introducing them and explaining their role to the patient and to the family. But really it's my job to explain to the patient why we're doing these things so that the patient understands, complies, and looks forward to the next stage. So what exactly should be happening? Well, Again, my job is to assess the patient's medical condition. I need to understand if they have heart disease, if they have renal failure, if they had underlying asthma or some other pulmonary disease, how that might affect their rehabilitation and their recovery. We know that the cost of energy to walk with a lower limb prosthesis is higher than people with two native limbs. So therefore, understanding their underlying cardiopulmonary status may predict a little bit about how well they will do with a prosthesis. So that's my job in the assessment phase. The physical therapist and occupational therapist will also evaluate the patient's current functional status and the current self-care status, and they will work towards achieving independence even before they get their prosthesis and receive the full comprehensive rehabilitation. So that assessment may take a few days and really get the patient started towards learning how to help themselves. Now, in addition to that, there is commonly some pain, and we have to make sure that we distinguish the different types of pain and the treatment for each. Surgical pain is commonly treated with narcotics early on and then tapered down to non-narcotics and ideally stopped as the surgical site heals. Residual limb pain is something that the patients understand. Phantom limb pain, however, in the body part that's absent is more difficult to explain to the patient or to the family, and the treatment is more challenging. The patient may well have had neuropathic pain prior to surgery due to underlying diabetic peripheral neuropathy, or they may have had some other catastrophic injury causing pain. So the treatment for this type of nerve pain is very different. And then finally, the patient may have other underlying pain. They may have had previous back pain, hip pain, or other joint pain that is related to osteoarthritis that now may be exacerbated by the different type of mobility. Then the psychological issue. This oftentimes is the most profound impact on the patient or perhaps family. Patient may have been prepared for it. If they have underlying diabetes and vascular disease, we start talking about the prosthesis very early on. We may not be ready to order it right now, just a few days after surgery, but we at least have to explain to the patient what it is. Most patients have no idea what to expect. Some patients will think that you just put it on once and leave it on forever. Some people think you put it on and leave it on 24 hours a day, but take it off only when you want to. Some people think that you magically just get up and walk the first day. They perhaps have zero idea about what happens. So my job is to explain the timeline, the process, even show them a prosthetic device. It's not unusual for me to hand them a prosthesis and say, this is what it's like. This is what it feels like. There are hard parts to it. There are parts that improve your performance, and that's based on the components, the parts that we select. That process from amputation to prosthetic fitting likely will take anywhere from 3 to 6 weeks, assuming there is good healing of the residual limb. Healing and shaping of the limb is critical in preparation for prosthetic fitting. The healing takes place through good wound management if there's anything there, protection of the limb, making sure the patient doesn't fall down and land on their amputation site, but the shaping of the limb requires compression and elevation. Compression comes from proper ace wrapping of the limb. There is a figure 8 pattern that is commonly taught by the therapist or by myself. If patients forget, there are educational videos, even on YouTube now, that will show you or refresh your memory on how to properly ace wrap the residual limb. That ace wrapping requires compression 23 to 24 hours a day. It's removed only for bathing or toileting activities when it might get wet or soiled. Otherwise, compression and elevation throughout this entire pre-prosthetic and even the prosthetic phase later on to maintain the shape of the residual limb. It's not unusual for their limb to start off a little bit bulbous, wider at the bottom, but the goal is to get them to a cylinder shape, because if the weight-bearing area proximally is smaller than the distal end, it's hard to get a socket to fit on there properly. So healing, shaping, educating, that's the vast majority of what happens during this pre-prosthetic phase. The critical muscles that are sort of strengthened or assessed during this phase are typically hip extensors, knee extensors, the muscles that are critical to get from sitting to standing and then maintain upright positioning. So I want to make sure that the physical therapists are really focusing on the proper muscles to get this patient walking in the near future with a prosthesis. And let's not forget about the arms. We use our arms for every assistive device. And when we use an assistive device, we're actually pushing down, not pulling up. So the muscles we use to push down would be the triceps, the pectoralis, the latissimus. So I educate the patients that you can do your own exercise program anytime you're sitting in a chair with arms, basically pressing down on the armrests, lifting your backside off the seat, and essentially doing a push-up in your chair, we call them wheelchair press-ups, is an ideal way to exercise all the muscles necessary to use an assistive device. Because when a patient gets a prosthesis, they're going to be using parallel bars, a walker, crutches, or a cane, and then ideally migrate to something where they have the minimal assistive device possible, maybe no assistive device. But in the early days, when they're first starting, they're always holding on to something. So those are the critical features that we have to talk about. We also start introducing the idea of the differences in componentry. Patients have little or no understanding about the components of a prosthesis. The socket itself is the custom molded piece that goes onto their limb. The understanding of how that is made, the fabrication time is critical. So we start to explain that process. If the patient's limb looks well healed and well shaped at 3 or 4 weeks, then the next step would be taking a casting of their amputation limb. Sometimes some prosthetists prefer to take a scan or measurements, but all 3 ways can be very productive to capture the shape of their amputation limb. And from that shape, we then fabricate the socket. That's the most critical part of the prosthesis, because if the socket is not comfortable, the patient will not wear the prosthesis or will not do well. The rest of the parts, the connectors, the knee, the foot, are essentially all parts that we put together, but the selection of parts is critical, and we'll talk about that in a little bit. So for now, explaining to the patient, this is what happens, once your wound is healed, once your limb is shaped. We take a casting of your limb. It still takes 2, maybe 3 weeks fabrication time to make a definitive socket, put the parts together, do an initial test fitting, do some adjustments, and then final delivery to the patient. So now where are we now? If it took a minimum of 3 to 4 weeks of healing and shaping time, it takes another 2 or 3 weeks of fabrication time with the prosthesis. Now we're oftentimes 6 or 8 weeks after surgery already. In the meantime, the patient has been in a wheelchair or hopping around with walker or crutches. They've still been at this sort of high-risk kind of situation where the risk of falls is very high. We want to constantly reiterate with the patient the prevention of falls. As we start talking about prosthetic feet, I explain to them that there has been a system of categorizing prosthetic components, knees and feet, for 25 years. The system was established by Medicare and has been adopted by many commercial insurances. And as the patient may ideally advance from lower levels, level 1 or level 2, to higher levels like level 3 or level 4, then the sophistication of the parts increases, the higher performance of the components. But ideally, the selection of the parts matches the patient's activity. If a patient comes in and says, I really need this high-performance foot or this high-performance knee, but yet they were barely walking outdoors before amputation, it doesn't make sense. So we have to explain to patients that what they may have seen on TV or seen on the internet, unfortunately, doesn't make sense for them, but we have a better design or better choice for them. So a lot of that education has to take place. It is not unusual for family members to come in with questions at this phase about when are they going to get fitted, how long is it going to take, how much is it going to cost, does insurance pay for the prosthesis? And all those questions are ones we should be able to answer clearly and concisely. We all know that Medicare pays 80% of all durable medical equipment, so therefore there's a 20% left over. If they have a good secondary insurance, it may cover. If they don't have a secondary or there may be restrictions, the patient may be liable for a certain amount of this. With that being said, let's move on to the next phase, which will include a little bit more about the actual prosthetic fitting and the training itself. So once the patient receives the prosthesis, how long does it take to learn? Well, the reality is it depends on your previous underlying medical conditions and your level of amputation. I generally explain to patients that amputation below the knee will typically require at least 4 to 8 weeks of outpatient physical therapy training. That's typically 3 times a week. And the training itself is educating the patient on what to do that they then practice at home. They will go through a progressive ambulation program where they start with more assistive device, working down to less assistive device. So it's the physical therapist's job to make sure they're doing things safely. If they have stairs in their home, we have to teach them how to get up and down stairs safely. If they have any other responsibilities of caring for other individuals in the home, we have to teach them how to do that safely. Toileting, getting in and out of a bathroom, doing that safely. And simple things like, can I go back to walking my dog? Can I go back to driving my car? those may require special attention based on the individual patient's care. But remember that amputation above the knee is actually more difficult because now you are controlling two different joints, the knee joint and the foot and ankle mechanism. That training time will take significantly longer. So I would essentially tell patients to double that time, a minimum of 6 to 12 weeks of training time to resume what we might consider a normal functional ambulation both indoors and outdoors in the community. Now that again should be done as an outpatient, typically 2 to 3 times per week, slowly progressing through their assistive devices. Ideally, most of my patients get to a point where they do not need an assistive device. However, if the patient has a balance disorder, has peripheral neuropathy that affects their proprioceptive feedback in the remaining limb, they may need to use a cane or a crutch long-term based on their other underlying conditions. Their overall fatigue and endurance may also be compromised. We know that the energy cost for amputation below the knee is different for amputation above the knee. If the patient has cardiac disease and they had an ejection fraction of 30 prior to amputation, now they have amputation above the knee, they may not be able to resume unlimited community ambulation because of the energy cost of walking with a prosthesis. So these are all things that we have to take into account as we develop the training program, as we order the prosthetic device, as we discuss with the patient the timeline of how long this will take and what their end result or goals might be. But now look at what we've talked about. From day of surgery, day of amputation, we already talked about 4 to 6 weeks of healing, 3 weeks of fabrication time, 1, 2, even 3 months of training time. This is now already a 5-month timeline. And that's the thing that patients need to understand. So it doesn't mean that there can't be some acceleration or deceleration of that program based on their progress, but that's an average. Patients need an estimate because they have to tell their families. If they were working previously, they have to inform their employers. When might you come back to work? Now, the demands for higher level activities such as sports, fitness, or return to work, those will need to be addressed separately. So, what about the prosthetic device itself? Well, most of you are aware that Medicare has allowed us to provide 2 prosthetic devices within the first year. The first one is typically called a temporary or preliminary prosthesis. The second one is called a permanent prosthesis. Now, both of those terms are misnomers, and I'll explain why. The first device is, in a sense, typically a simpler, lower-level type of prosthesis whose goal it is to restore basic ambulation indoors and perhaps a little bit outdoors. But it will essentially become the spare tire or spare leg later on once that second, more permanent prosthesis is developed. So the first prosthesis is essentially fitted as early as possible once the healing and shaping is suitable. We anticipate that there will continue to be changes because the patient's limb will continue to shrink down, and it will shrink differently. It will shrink more distally on the residual limb and less proximally. So we have to anticipate the patient will have to learn sock management, adding socks onto their prosthesis or onto their residual limb, or padding or modifications to the prosthesis. And a lot of changes will occur with this first preliminary prosthesis. Now, it is still designed to last for a long time, but its goal is really to achieve that basic ambulation, get through the training period, and have the patient basically achieve 2 milestones. The first one is basically hitting a functional plateau, meaning they've gotten as far as they can with this particular device in physical therapy, with their ambulation and with their activities. The second goal is to achieve stabilization of their residual limb. Once their limb shape is stabilized, they're no longer requiring the addition of socks or padding over a course of 2 or 3 weeks, then that's the signal to us that we're ready to move on to the second, more permanent prosthesis. Now again, permanent is a misnomer because the expected lifespan of that second prosthesis is 3 to 5 years. And along the way, we can still make adjustments to that prosthesis. We replace the soft goods, things like gel liners, sleeves, socks, and any part that actually breaks during that 5 years can still be replaced. But the hard parts of the device oftentimes should last for several years easily. Now, does the patient need further instructions lifelong? Absolutely. And so we're going to talk a little bit about the selection of componentry and the lifelong management next. When we talk about amputation below the knee, for a preliminary prosthesis, there really are only 3 primary components. There's always the socket, there's the pylon, and there's the foot. As far as the socket design, most of the time we have a more durable outer laminated carbon fiber frame with some type of soft interface material. The most common selection nowadays is a gel material. There are a variety of manufacturers that provide different thickness and different density of these gel materials. For the preliminary prosthesis, we typically don't have a direct connection of the gel liner to the prosthesis as we might see in a permanent limb. But we do need some more form of suspension. So we oftentimes use a sleeve on the outside that attaches partly onto the socket and then rolls up onto the patient's limb. The pylon or connector pieces are oftentimes lightweight material, such as aluminum, titanium, but for a heavyweight patient or a heavy-duty patient, these might need to be stainless steel or carbon fiber. So the first prosthesis is intended to be light, simple, appropriate fit to start, but the anticipation that we'll have to add socks or make other modifications to this device. As we move to the more permanent prosthetic device, the same three parts are still there: socket, pylon, and prosthetic foot, but some things change. The gel liner may still be the interface material, but it may also work as the suspension, using a metal or plastic pin that locks into a receptacle inside the prosthetic socket, and that's what holds the patient in place. The beauty of this is that now we've eliminated that outer gel, we've reduced some of the weight of the prosthetic device, and to a certain extent, the bunching up of material behind the knee, which is critical when patients want to bend their knee for kneeling, crawling, climbing stairs. The prosthetic foot, again, is based on the patient's functional activity. Most of our patients will start off at a lower level, perhaps a level 1 or level 2, many with the goal of returning to level 3 activities, which are unlimited community-based activities. And then carbon fiber feet become an option. Carbon fiber is the most common material used for prosthetic feet. Carbon fiber has some memory to it. When you deform it, when you bend it, it springs back and gives you propulsion. So therefore, it's not simply holding you up, it's also pushing you forward as you walk. That deforming of the carbon fibers and that restoring of propulsion is critical for faster walking, longer distance walking, and higher level activities such as running and jumping. Interestingly, carbon fiber is not the only material that does that. Now, in the past 5 years, there's been some advancements in fiberglass composite materials. So now we have fiberglass composite feet that work in the same fashion. Their weight and cost is about the same. Their dynamic response is very similar in the sense that they store energy and propel you forward. They're essentially the same, except we have found anecdotally that our patients feel a little bit smoother rollover as they walk. Also remember that the length of the carbon fiber or fiberglass pylon makes a difference in its performance. When a person has a longer amputation limb, or if there are other components that are installed, such as shock absorbers and rotators, then the carbon fiber length is kept short, and the dynamic response, meaning the propulsion, will be less. So a taller or longer carbon fiber or fiberglass length here will give you more bounce, more propulsion. A shorter one will give you less. So let's talk a little bit about above the knee amputation. We now add the obvious component of a knee joint, so we'll look over here where we still have a socket, we have a knee joint, we still have a pylon, and we have a prosthetic foot. The selection of socket design and socket materials is always a negotiation with the prosthetist. We inevitably require multiple layers of material to make this comfortable. As many of you know, an above-the-knee amputation requires that the socket actually goes all the way up to the groin crease, captures the ischium, and even halfway up onto the gluteal muscle, which makes this medial brim and posterior portion of the socket uncomfortable if it's not designed perfectly. So we have materials to make that transition from a hard outer material, which is oftentimes a laminated carbon fiber, with a softer, more flexible plastic brim, and then a softer, more flexible inner liner material, which again, oftentimes is gel, but could also be socks. Inevitably, the softer material goes against the patient's skin first. There are a variety of gel materials available, different thicknesses, different densities. This goes on the patient's limb first. The patient then slides into the prosthetic socket. There are a variety of ways of holding the patient in. We can still use a pin mechanism that locks into the bottom of the socket. We can use a suction system where there's an air seal created between the gel liner and the socket itself using a one-way valve or an elevated vacuum pump. Or we can have the patient's skin directly against the inside plastic material, which has historically been a true suction fit design. It gives the patient the most intimate contact with the prosthesis and the most intimate feedback from the ground as they walk. However, the patient's amputation limb has to be ideal, with good soft tissue coverage, good sensate skin, and then they may be a candidate for this true suction fit without using a soft interface such as a gel material. Obtaining the contours of the socket is in the responsibility or realm of the prosthetist. Again, whether they do a true casting, a scanning, measurements, modifications, that's really up to them, but it's my job to make sure that it's a proper, well-suited fit, the patient is comfortable, that we're getting appropriate ischial containment into this posterior segment here, and that the patient is comfortable and happy with their prosthesis. But as far as knee component selection, again, the Medicare guidelines for 25 years have given us instructions on how to categorize prosthetic knees. Of those 4 categories in Medicare functional levels, we're basically allowed to use the simpler components, kind of the safer components for our less mobile patients. There are locked knees, which manually lock and stay locked throughout the gait cycle. There are stance control knees, and I'll demonstrate very quickly that this knee, when there's no pressure, is free to swing. However, when I apply pressure, it becomes locked. So this is a weight-activated lock mechanism that oftentimes is used as the starter knee for a person with above-the-knee amputation. The intention is that at heel strike or initial contact, they load the limb, it locks the knee, they roll forward through mid-stance, terminal stance, and pre-swing. As they start to offload the limb, they capture the toe on the floor just for a brief fraction of a second, and then swing the leg ahead. It's an elegant design that's been around for decades. It works remarkably well. But as patients get more and more sophisticated, they'd actually like to have some knee bending as they walk, because that's normal gait. To have knee flexion throughout mid-stance, you certainly need knee flexion while it's loaded to ascend and descend stairs. So getting to the next categories that include hydraulic and microprocessor controlled knees oftentimes is the goal for many of our individuals that have returned or will return to community-based ambulation. They have to tolerate uneven terrain, up and down hills, tolerating up and down stairs, and realistically even returning to recreational activity or sports if they were involved in those before. Now, what might change on a permanent prosthesis for above-the-knee amputee? Oftentimes, the socket design may change somewhat, particularly with the suspension, but certainly an upgrade in the componentry for the knee and the foot may be required if the patient has improved or progressed through their training program. As an example, we'll look at this prosthetic knee, which is a typical hydraulic knee mechanism. It's still allowed to flex, but there's controlled flexion and extension, and that is adjustable. If this were a microprocessor-controlled hydraulic, it's adjustable by the prosthetist using a computer program. If it's a standard manual-controlled hydraulic, the patient can actually make some adjustments themselves, turning the wheel in the back. So the issues about permanent prosthesis also have to take into account the patient's sort of tolerance to weight. We haven't talked about this yet, but oftentimes the preliminary prosthesis is lighter than the second, more permanent prosthesis. This hydraulic piston is going to add nearly a pound of weight to the prosthesis. Now, is that going to make a huge impact for a higher level patient? Likely not. But for a lower level patient with cardiopulmonary disease, the additional weight of some of the more sophisticated knees may actually be a detriment, and we have to understand and take that into account. So those are some of the issues we will have to accommodate as we make our discussions. I typically see these patients soon after delivery of any prosthesis, and then if they're doing well, I'll see them 1 month later, then after that 3 months later, 6 months later, and then likely once or twice a year for the rest of their life. Because things will wear out, the components will wear out, the socket design may require some modification or adjustment. As I mentioned earlier, the soft goods, meaning gel liners, socks, will wear out and will need replacement. Sometimes even the hardware will require modification or replacement if there's some kind of malfunction or breakage that occurs. So remember, it's your responsibility as the physician, the team leader for this group of professionals to make sure that the patient comes back and follows up. They may gain weight, they may lose weight, their activity level will change. They may literally jump from one category to the next, up or down, based on their activity and their medical condition over a course of years. And it's our job to keep up with that and make the appropriate adjustments to the prosthesis.